You are listening to the
World Extreme.
World Extreme Medicine.
The World Extreme Medicine
Podcast.
In this conversation, we're going to be exploring Gaza and disaster medicine, the lessons learned from recent global crises. So in the discussion, we wanted to delve into the unique challenges of providing medical care in conflict zones like Gaza and indeed other case studies, and examine how lessons from these recent natural disasters and humanitarian emergencies can better guide our responses. So our guest today is going to share some key insights and practices to better prepare for future global emergencies from his perspective. So to do this, I have Hareen De Silva with me. Hareen's no stranger to the podcast. He is a seasoned humanitarian with over 5 years experience in conflict zones, natural disasters, and other crisis settings. He has worked with various organisations such as Medical Volunteers International, CADUS, and UK Med. He's also led medical response teams in high-risk environments, various locations globally. So his expertise spans both trauma care, public health emergencies, and logistics of healthcare delivery in resource-limited settings. So Hareen has played a crucial role in both immediate medical response and indeed long-term recovery efforts in places like Gaza, Ukraine, and Syria. Welcome to the podcast, Hareen.
Thanks very much, Eoin, for having me into World Extreme Medicine.
I wonder if you just kick off and start by just digging into some of your most recent experience, Hareen, if that's okay. You've just come back from Gaza, and could I get just to speak to how this context compares to others you've seen in the past, just being on the ground?
Yeah, so I think I've been back out of Gaza for just under 2 weeks now, and this is the second time I've been there this year in 2024. So I was there in March, and it's even worse than when I was there in March. I was there in March. I was there with CADUS, and this time I was with UK Med as their Type 1 clinic lead, which is their primary healthcare centre, and it was just much worse. We'll probably cover this, but a lot of the reason why it was so bad is logistics and supply chain of getting equipment in, etc. I think the last situation report from the WHO showed there was just over 41,000 people who had died and 97,000 injuries, etc. But obviously, this is an underestimate because, again, WHO in that same sit rep said there's probably 10,000 plus people that are missing under rubble in terms of the destroyed buildings, etc. And I honestly, to answer your question, comparing to other places I've been, Syria, Iraq, Ukraine, this is by far the worst humanitarian crisis I've ever been to. And as we've seen with the escalation in the Middle East, it's probably going to get worse in other countries such as Lebanon, etc.
Yeah, absolutely. And like you said, I think it's multifaceted as well. And maybe we could just dig into that because it's not just the water, it's just basic fundamentals, I guess, the water and sanitation, but also economical security of food and supply chain of just basic medical provision. And I guess it's a meld of all those. So just the living conditions, the medical provision, and otherwise. Was it on all fronts, Hareen, that you were struggling with?
For sure. And this is the problem, like you've mentioned, it's multifaceted and it takes a huge cross-sectional multi-response to basically meet the needs, which aren't being met at the moment for the people of Gaza at the moment. So water, sanitation, hygiene. So that's a huge thing. So the primary healthcare centre I was managing for UK Med in Deir al-Balah, we were seeing approximately 400 to 450 patients a day, 30% with skin issues. And that's basically boils down to the fact that there's inadequate access to water and inadequate access to simple things such as soap. So scabies, impetigo. I've never seen impetigo as bad as that in my life. Just usually you'll see it from a nursery age child in the UK with a bit on the face. This was widespread, the whole body, whole families, because of obviously people living in very close-knit community tents, maybe multi-family units in one 10-person tent, etc. It was basics of that, and then we see a lot of people with waterborne illness such as diarrhea coming in with dehydration, which will we'll assess and then just give IV fluids and basic antidiarrheals if we had them, or antiemetics if we had them, etc. if they're vomiting as well. But the big thing that that was very well publicised was the polio case, the positive polio case. And UK Med was involved in the polio vaccination campaign. So at the type 1 facility I was managing, we were able to vaccinate 1,600 children over those 4 days, which was a mammoth undertaking. And again, that's a huge logistical undertaking by the WHO, UN, and Ministry of Health there, just to get the vaccines in an appropriate cold chain manner and disseminate them throughout the various areas. So, and that involved speaking to Israeli forces as well, to have no fighting in certain areas to move this. And it's just across all fronts, the logistical undertaking of all of these organizations is huge.
So, Hareen, you mentioned there, a number of just disease pathologies which are manifesting in the Gazan population. Could I get you to speak to, so was this a mixed pathology? You were still seeing the sort of blast and ballistic pathology in amongst some more chronic disease outbreaks. Was it quite mixed?
So UK Med have 2 facilities. So the type 1 facility, which is primary healthcare, which we manage, but they also have a type 2 hospital, which has approximately 80 inpatient beds. On the 9th or 10th of September, we were woken up at midnight with a massive crash. We were all living in the hospital, as the guest house we were living in had been hit by a potentially tank shell a few weeks earlier. So it was just a huge rumble. Things were shaking. We woke up and there's a mass casualty incident, and that was, we had approximately 26 patients come in, two children, unfortunately, with bilateral amputations. I had to go and get the ultrasound machine for one of the emergency medicine doctors. And then I walked in with that ultrasound machine and then saw this probably 2-year-old with missing two cap tourniquets on their upper, above their knee, and just bleeding, or blood which had stopped from bilateral knee amputations. And at that point also middle-aged male with a huge piece of shrapnel, which was essentially, I have a picture which it's a huge heavy piece of metal which spans my whole palm, and it's incredible. So we get those at the type 2 inpatient facility. So we've got the trauma there. And then the simple things like the type 1 facility, our primary healthcare center, which is exacerbation of chronic non-communicable diseases. If you think that only 43% of the primary healthcare centers that were there before the start of 7th of October are still functioning now, you can imagine that there is a worsening of chronic health conditions, etc. So mental health disease, which unfortunately there are not many actors which are providing mental health and psychological support. And it's just a worsening of everything because you can't get in the medication. So we're using 2nd, 3rd, 4th line drugs sometimes for simple things such as hypertension, because we also don't have the consumables to monitor a lot of these things with the lab. So simple things such as starting some antihypertensives which need monitoring of the renal function we can't do. And so then you have to be very careful because there's no access to water, and you don't want to dehydrate someone or affect someone's kidneys because you know they're probably going to be dehydrated, and then you have another problem. And it's a constant pivoting and adaptability in the way you practice medicine in these types of situations. You have your protocols and your guidelines. Those cannot be seen as a rigid train track. You have to work around with what you've got, etc. And there was one announcement where there was a critical shortage of gauze in the whole strip, and the type 2 facility for UK Med had to cancel all non-elective surgeries such as hernia repairs, etc., and only pivot to emergency ballistic trauma type surgeries. So yeah, it's very, very difficult, and that's one of the many reasons why it's one of the worst crises I've ever been involved in.
No, indeed, indeed. Could I get you to speak to semblance of communication and indeed collaboration amongst different humanitarian actors? Was there kind of almost these plenary groups in sort of a huddle type scenario where there was sort of almost mass coordination? Was that a central feature?
Yeah, so as you know, any good humanitarian response involves a cluster of organizations. So for the health, WHO was the lead for that, and they were speaking to various actors which had various expertise. So UK Med is the only emergency medical team in the UK, and they're rated up to type 2. So they can do an inpatient hospital and primary healthcare. So we were strategically placed in areas where we could be utilized well, and then you have coordination like that. And then we're working with other organizations. So CADIS, who I now work with, they're the international health partners. So they do the medical evacuation of international staff members, but also evacuations of patients from north to south if needed for critical patients. So it's utilizing all of these actors. So there's a whole referral pathway where various actors are all within this group. So patients that are in the Ministry of Health hospitals, which are beyond 100% capacity, UK Med is in NASA at the moment. So they will say, we've got these number of patients here. Can we move them to any facility, such as the UK Med Type 2, IMC, International Medical Corps, ICRC, which have hospitals as well. And basically those medical coordinators would say, yep, we've got the capacity, we've got the expertise, we'll take those patients out of the Ministry of Health hospitals and take the pressure off them. We all are under-resourced. There is no two ways about it. And sorry, I have one key actor, MSF as well, obviously, have hospitals around the strip, but we're all under-resourced. And it's about sharing that workload and also donating items between ourselves as well. So UK Med have donated to various organizations, CADIS have donated to various organizations, and we've both received donations from various organizations, such as simple things as consumable strips. So an iStat machine, which is just essentially a plug and play mobile lab. There are so many organizations that use these but don't have the consumables because, again, there are certain restrictions on certain items which come under the dual purpose list, which can be seen as items which can be used for war, etc., which have microchips and essentially things like that, which are restricted. And this is a widely public accessible list, which people are curious can go and have a look.
So, Hareen, there was a semblance and still is a semblance of almost this constant major incident, and the major incident is more of a protracted one with internally displaced people and chronic infection starting to take hold. But could I get you to speak to any or how you approached any kind of blast and ballistic major incidents whilst you were there? Because I can imagine there's a number of surge events that occur. Like you said, you were woken up in the night by artillery shells. But could I get you to speak to your approach and indeed your experience of this last deployment of any sort of mass casualty surge events that you had to deal with?
So with the UK Med deployment I had just recently, so there was a whole mass casualty incident plan where people were designated roles. So UK Med has 20 international staff, but upwards of 400 to 500 national staff. So at the Type 2 hospital, at any point would have potentially 80 national staff working there. So they all have their role that's assigned to them for that. So we have a minors, majors, and resus and X-ray room. So everyone who's activated and knows where they are. The cleaners and the guards are aware of their roles. So you've got all those simple things. And then for me as a GP, and there was another GP who was taking over from me, we were assigned the green area, so the walking wounded, etc. So just assessing them and then either upgrading them to the next emergency medicine doctor that's needed, or popping them in an outdoor waiting area for further assessment if they needed just an X-ray later on for a possible fracture, etc. So we all have those roles, etc. But that approach in amidst that chaos, I was amazed at how well it worked. And UK Med have recruited very well when I was there, working from excellent colleagues. And as people may not know, UK Med was born out of the NHS from Manchester, and they recruit a lot of people from the NHS, etc. So it was just great to honestly, just a bit of pride being part of the NHS as an NHS GP. But essentially, we have a mass casualty incident plan. Everyone has a roles, so we'll be handling green, amber, red cases, and then it's just a constant flux. We didn't know how many patients were coming in. At that point, we had, I think, 26 to 40 come in, and then you have the relatives as well that's coming in, and then the guards are managing that very well. Then we have our logisticians who are managing the influx of ambulances coming in and out, and just making sure there's just that ability to rotate them in and out. And we work with a very great, amazing group of national staff and Palestinian Red Crescent Society as well, who do all of the ambulance dispatching and obviously collecting casualties. So yeah, and it's slightly different to what we did at Cadus in March, which was involved in a trauma stabilization point alongside the Palestinian Red Crescent Society. So we'll be working collaboratively together, and we were the only trauma stabilization point in that area in Khan Yunis. So, and anything would come in. So mass casualty incidents, children, babies, etc., being with gunshot wounds, ballistic injuries. So again, being a GP, I was just involved in sort of just making sure the equipment was there, moving patients that have been declared green, etc., alongside our colleagues, and just letting the emergency medicine specialists and trauma specialists get on with their job, and just making it slightly easier for them. Everyone has a place. It's just you have to practice before, you have to know your roles before. And anyone who's going out into areas like this, please read all of your SOPs, protocols, whatever. They're there for a reason. They're not a boring read. They will come in handy when you don't have the bandwidth to actually pick up that piece of paper. If you've, I wouldn't say memorize them, but have a basic understanding of your role and talk through them. And always dry runs are great as well. So we're lucky that we communicate very well, where we're able to talk through them and debrief as well. And that's so important after a mass casualty event, is to debrief psychologically, and also where things could be improved moving forward for the next event, which will come.
So, Hareen, I'd like to pass apart a couple of questions, really. One would be around calling forward and pulling forward your experience from Syria. It's very different context, in essence, to Ukraine of sorts, and different maybe to your experience in Ukraine. But in Syria, there was very much this semblance of a real lack of infrastructure, because places like Mosul were being razed to the ground. There was absolute deprivation in areas like that. Could I get you to speak to what you took forward from your deployment in Syria to Gaza, and any similarities, any differences, and anything that you sort of called forward?
I think in any deployment, one thing that any humanitarian should be thinking about is culture and context. There is no plug and play thing. You can take experiences forward, but you have to adapt to the culture and context. So in Syria, I was doing health needs assessments in Raqqa. And again, you said the infrastructure is completely destroyed. So we went to the main national hospital in Raqqa, and we're a health actor, Cadus, when I was there with them, but we are thinking about simple things such as, can we bring in solar panels to power the hospital in terms of generators? So it's not always health that's really important. And it's the thinking widely about that, and where you fit in a collaborative manner with the cluster as well. So that's really important. So that adaptability and that context, the ability to think within context and culture is really important. And then if you take that forward in Gaza, it's still an emergency response, essentially, with the constant shelling, etc., and airstrikes at the moment. So everything's constantly going on. So it's thinking about the long-term impact as well. So we were there for quite a long time, 5 years in Syria. It was different when we started in trauma care. on the front lines, and then working in the Al-Hol refugee camp, managing a hospital there. And it's just forward planning. So UK Med have their future plans, etc. And CADUS at the moment, which we're thinking of, is what our future plans are there. Providing health at the moment, it's just responding to trauma at the moment. That's where our wheelhouse is. But that's what needs to be done. It's thinking forward and bringing that forward, etc. We're a new, CADUS is a new emergency medical team, only verified a couple of weeks ago as type 1 mobile fixed unit, which is primary healthcare essentially. So we also have to now think about what we can do there moving forward. Part of that also is appropriate recruitment of people. So thinking, looking at the profiles. So we've been exclusively recruiting trauma specialists or emergency medics or anaesthetists to work in the trauma stabilization or medevac context. But now with my experience with UK Meds managing their primary healthcare centre, we can bring this forward. And again, it's learning experiences everywhere. And that's what you bring in. I saw the devastation of 10 years on from the start of the Syrian conflict. The fact that you need the infrastructure, this very simple thing of brick and mortar buildings, appropriate toiling facilities, water facilities for simple things such as hand washing, showering, etc. And that's not there. And I mentioned before, 43% of the primary healthcare centres that were there before the 7th of October, so only 43% are functioning compared to the 57% that have been destroyed now, unfortunately, permanently closed. And that's going to be a big thing. And again, it's rebuilding these in the appropriate places, etc. And it's not even health, it's school. Like 645,000 children have missed the school year now, according to UNICEF. And that's, if you education at such a young age is important. Obviously, the psychological trauma that children have experienced now, which will, as we know, has shaped, will have a long-lasting effect moving into adulthood, and obviously the malnutrition that's there as well, that will have a long-lasting effect of children probably stunted, not growing to their full potential, and their brains not developing as the way they should. And this is so important to think that the experience I've taken forward from Syria, you have to work collaboratively with all of the organizations, all of the sectors, WASH, food, nutrition, and protection and education clusters and logistics clusters, obviously. And that's what I've taken before in my time in Syria. And now I'll take forward into my future career.
Yeah, Hareen, it's powerful in a way because, as you said, fundamentally, it's this. So the water, sanitation, and hygiene. It really belies good public health, and when that's not functioning, the public health and the chronic disease starts to come to the fore. And indeed, waterborne disease and sanitation manifests in a lot of ways. And like I said, that poses a whole different array of problems actually for teams. But something you just really just touched on there, which is equally as powerful, is really the unseen vicarious trauma of the psychological burden on kids and the destabilization, the lack of, like you said, education, but the psychological trauma. You said this earlier, and I guess my pivot and question on the back of this, because you said it's really, and it is hard to address both physical and mental health needs when it's really even hard to extend the full suite of physical needs and physical medical provision for people in Gaza, but then to address you're right, the mental health burden on children and indeed families. Could I get you to speak to, you mentioned how important debrief is, and it really is fundamental from just reevaluating what went well, what maybe didn't go so well. But could I get you to speak to the psychological burden on medical teams actually? I don't necessarily think the debrief goes the full way in mitigating psychological burden, but it does go some way. Could I get you to speak to how indeed you decompress, or indeed what the standard operating procedure is for UK medical teams when you've had such a visceral experience in places like Gaza?
So the good thing is with UK Med, they've been well established for many, many years. So they have processes which they've probably learned from the start to where they are now. So there is the access to psychological help through private health insurance company, which they use. So utilizing that, I still need to utilize that. So I've got the email address and number. For me personally, I always taking care of your mental health should be up there, taking care of your physical health, feeding yourself, watering yourself, etc. And I think that's neglected to some degree for healthcare professionals around the world, whatever. And I think the great thing with mental health illness is it's been brought into the light, and it's acceptable now moving forward to recognize that's a very important thing to address and to look after. So I need to utilize that in terms of just general day-to-day stuff on deployment. It's making sure you, so World Extreme Medicine summed this up very well in their recent social media post on World Mental Health Day, with various faculty addressing that. So making space for yourself, having your home comforts when you're in deployment, making sure that you're eating and drinking well, and talking with colleagues. So there is a burden, there is a toll. I would speak, so I speak to my various colleagues out there in UK Med, sorry, after every day. And you can tell with the 5th mass casualty incident that's happened in one day, which has happened, and you're thinking 20-30 people involved in that, children most probably, you potentially could lose that humanity in terms of all you see is war and violence and destruction. And that's not what you want. You're trying to be there as humanitarian, working to help people, etc. But you're just seeing things worse, and that's in all areas where there is conflict involved in that. But then you also look towards climate-related disasters in terms of global warming. You think, what are countries actually doing and governments around the world doing to address this? Because it's going to get worse. For you and I, as working in the humanitarian field, unfortunately, we're not going to be out of the job. But there will be a point where I've had enough of this mentally. Just seeing children with blown off limbs, or another group of displaced people because of a flooding or a hurricane, which has been created by global warming, climate-related issues. So it is a burden, but you have to also reach out to the people that understand the context. So you have your family at home and your friends, etc., but they are great to lean on, but it's making those friends and colleagues and moving forward. So some of the greatest friends and colleagues now are the people I've deployed with before, and we always check up on each other. So Lucy Williams, who's and Laura Jones, who are faculty of WEM, they've both been to Gaza, and we just randomly drop a message to each other when we know we've been out somewhere or something like that. And that's part of the humanitarian ethos and family aspect of it, is looking after each other. But yeah, there are so many methods of people. So I do a bit of meditation. I make sure I've got my music and my street films and TV programs, which I look at, and make sure I have time to decompress at the end of the day. But pushing the old days of pushing all your feelings to the bottom of your stomach, we need to move away from that. Honestly, it has a place when people respond differently to mental health, stress, etc., which is fine. But you have at some point you have to recognize that it may affect your work, so you have to address that in whatever way you see fit, or whatever way helps you to deal with that. And that's basically the most important lesson here: is don't ignore it.
So just a couple more different questions, Hareen. One would be something we just spoke offline about around safety, really, and the compliance to international humanitarian law. Both ICRC, the World Food Programme, Médecins Sans Frontières, so Doctors Without Borders, have all had their own security issues, actually, and some absolutely tragic losses, both in recent times and extremely contemporary times, actually. Could I get you to speak to your thoughts on security in what is a very dynamic and kinetic environment, and one in which the goalposts seem to change quite frequently?
So yeah, the goalposts are changing. It's very difficult to feel that you're remaining safe. There are processes in place which basically makes your locations visible and your movements visible as an international humanitarian organization or a national humanitarian organization. But it's really important also to think about international humanitarian law, so distinction, proportionality, humanity and necessity, so which govern the law of war and rules of engagement, etc. So as long as they're looked at and followed, then we, as humanitarian aid organizations, we have to remain neutral in this process. One of the mass casualty incident that affected UK Med, and there was a strike on an area of tents, which affected so many children, women, civilians, etc. But apparently there was a key military target that needed to be engaged there. So you look at that and see, has all of these been followed in terms of international humanitarian law? And I can't speak to that. I'm just there to provide medical care. But in terms of the international actors, etc., so you mentioned all of those organizations that have been affected with, unfortunately, deaths, and World Central Kitchen was one of them in April when I was working there on the ground, etc. And UK Med hasn't been immune to this as well. Our guest house was hit, and which destroyed the whole top floor. We weren't there because we had moved out because of an engagement outside between Israeli forces and other forces or actors or combatants, etc., unknown. But we moved out because it was just too dangerous. And then the next day, etc., that whole top floor was gone. And it's a dangerous place. It's probably the most dangerous place you can be in at the moment because things are unknown. Things could happen. It's not like in Ukraine, where the front line's on the east, and then if you're in on the west coast, sorry, not coast, the western side of Ukraine, you're almost immune, but obviously missiles do fly in and out of the area. But at the moment, the whole strip itself is a target. And you think of the humanitarian zones which have been set out in Gaza. That strike that caused the mass casualty incident was within that zone. So it's very difficult to know where the goalposts lie and where you should operate. And for us as actors, international actors and national actors, this becomes a problem in terms of access as to where we can go, where we cannot go. And obviously there's that fear you don't know what's going to happen. Because if your house is marked, your guest house is marked with a giant flag, a UK Med flag, which is visible to the drones, and a flag that's flying in the wind, which is visible to, well, we don't know, to planes and tanks and ground soldiers, etc., and it still gets hit, then you just don't know, do you?
Yeah, Hareen, totally. No, totally. And it's just such a gamble because, like you said, it's reliant on both forces upholding international humanitarian law and paying credence to that, which is challenging very much at all times. Just a couple more questions, Hareen, before we come into land. One would be around, you've got a unique opportunity at the moment. You're now a medical director of CADUS, humanitarian actor in the field, and really to shape both SOP, standard operating procedures, but also the way medical teams interact on the ground. What are some front of mind priorities that you calling forward your experience? What are some of the priorities you're looking to shape within CADUS as a priority to you?
For me, it's pivoting away from that emergency medical team trauma response. We can still have that for sure. That's part of the CADUS structure. It's been what we've been doing for the past 10 years. But now we have to look forward to primary healthcare, maternity health, etc., because we've been rated by WHO as a type 1 mobile and fixed. So, and that means we have to potentially provide upwards of 100 primary healthcare consultations a day. So part of that is recruitment. So at the moment, we have 1,600 people on our database. 93 are fully prepared in terms of the e-learning modules, the face-to-face heat courses that we do, and fit the profile of having the advanced life support, pediatric life support that we need for deployment. But we have to expand that now to primary health care. So one of the priorities for me is looking for someone involved in maternity care, such as a midwife, who can come in and help shape our how we offer that care moving forward, and having those profiles. And this is the thing, it's a profile. So we need to build those profiles of people who have the right experience. And it's not just the medical experience. This is really important as well to think about. Can you live with that person for 4 weeks or whatever in cramped conditions, eating camp food, having a shower every couple of days? Is that person adaptable and still have a smile at the end of the day, which shouldn't be forced, but have the ability to still work cohesively, socially and professionally in that thing? And so part of that is also looking at that. We have a very good HR team which does a lot of the recruitment stuff, checking certificates and making sure people have the appropriate level of qualifications. But the interviewing process is going to be really interesting moving forward. Is how do you judge someone's character in what 30 minutes to 60 minutes, and figure out, are they the right person to send? And yeah, so that's going to be quite a challenge. Also, it's preparing for other issues. So at the moment, I'm on my desk at the moment is writing concept notes for Sudan and Lebanon to see if we have the capacity to deploy there. So part of that is looking at the equipment we have in storage, what we need to buy, etc., and thinking about, can I staff, can our department say that we can staff this project for 2 weeks, what equipment we need, what medications we need to do. And then we have this whole project management team that also looks at the logistics of that, and obviously logisticians. Can we take in controlled drugs into this country? What is the security like, etc.? But this again is working collaboratively within the organization, within teams. So the good thing is I just concentrate on the health aspect of this, the recruitment, what we need, equipment, medications, etc. And then we have a great team here in Berlin. So
no, listen, that's fantastic. And as you said, really interestingly, Hareen, there's a real human factors piece around intra-team dynamics and internal team dynamics for what are, highly stressful and pressured situations for short periods of time. It's almost this flash team concept, but it is this longevity of, can you still function hopefully as a polite and normal human being with sleep deprivation, maybe a little bit hungry, maybe a bit tired, not having the same wash facilities as normal over a week or 2 weeks or 3 weeks. And it's really interesting that to sort of bring that to the fore, because that certainly is, like you said, a central facet of what happens on the ground. And it's having the continuity of character to just to bring teams into that environment, and because service provision is probably the most difficult that you can. I mean, I remember you experiencing your time in Ukraine, just such a challenging environment in the depths of night, transferring war wounded casualties, but also just having these fluctuating and indeed dynamic situations, and being able to be consistent characterologically in those environments is a challenge. So I totally hear you, and reach back into my own experience to really agree with you on that, Hareen. But listen, fantastic just to get your thoughts and experiences, and thank you for your time for this past hour, and also just for being open and honest about your recent experiences. It's really insightful, I think, for the wider WEM audience, just to really hear how it is on the ground. And listen, what we'll do is we'll put in the show notes links to CADIS, and also to some of the contemporary challenges in Sudan, because like you said, it's sometimes not necessarily covered in the news, but certainly is a bubbling and humanitarian crisis in Sudan. So we'll certainly do that. But thank you, Hareen, for your time.
Thank you very much, Eoin, for your time.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars and indeed a collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.